My name's Jennifer Saw, and I am a GP at the Lawson practice. Um, Today, I'm working in the role of the clinical lead for learning disabilities in what used to be City and Hackney CCG, and I haven't learned the full title yet of what we have become, but something about North East London CCG. And today I'm joined by members of the Integrated Learning Disabilities team, led by David Pryor, who is working as a psychiatrist in the team. Now, I just have a few things to say that are more GP related, and then David and his team are going to talk in more detail about the ILDS service. And do bear with me, as I say, we're using a different platform today, so if there's any hiccups with it, just be gentle. So basically with the learning disabilities, I just wanted to share a little video with you. Forgive me if you've already seen this, but it's just to start with, and it's only just for a few minutes, so just bear with me. And play.
Everybody line up. Shoulder to shoulder. Take off your backpacks. Basketball, line up. We're about to. Hey, we are racing for a $100 bill. The winner of this race will take this. A $100 bill. Before I say go, I'm going to make a couple statements. If those statements apply to you, I want you to take 2 steps forward. If those statements don't apply to you, I want you to stay right where you're at. Take 2 steps forward if both of your parents are still married. Take 2 steps forward if you grew up with a father figure in the home. Take 2 steps forward if you had access to a private education. Take 2 steps forward if you had access to a free tutor growing up. Take 2 steps forward if you've never had to worry about your cell phone being shut off. Take 2 steps forward if you never had to help mom or dad with the bills. Take 2 steps forward if it wasn't because of your athletic ability, you don't have to pay for college. Take 2 steps forward if you never wondered where your next meal was going to come from. I want you guys up here in the front just to turn around and look. Every statement I've made has nothing to do with anything any of you have done. Has nothing to do with decisions you've made. Everything I have said has nothing to do with what you've done. We all know these people up here have a better opportunity to win this $100. Does that mean these people back here can't race? No. We would be foolish to not realize we've been given more opportunity. We don't want to recognize that we've been given a head start. But the reality is we have. Now, there's no excuse. They still got to run their race. You still got to run your race. But whoever wins this $100, I think it'd be extremely foolish of you not to utilize that and learn more about somebody else's story. Because the reality is, if this was a fair race and everybody was back on that line, I guarantee you some of these black dudes would smoke all of you. And it's only because you have this big of a head start that you're possibly going to win this race called life. That is a picture of life, ladies and gentlemen. Nothing you've done has put you in the lead that you're in right now. When I say go, on your mark, get set, go!
Right, so I think we can guess the outcome from that quite well. So let me just turn that volume down, bear with me.
If you didn't learn anything from this activity, you're a fool.
As I say, bear with us. Okay. Can you still hear that? Sorry.
Yes, we can, Jen. Do you want to just close the window with the video on? Yeah.
Trying to. Okay. Right, we're there. Okay. So that was just a little demonstration, I think, about inequality. And the reason I bring that up is really to demonstrate that in essence, people with learning disabilities are, you know, if you could even take 2 steps back, I think that's where people are. And what we need to be thinking about is to rebalance the inequalities. Now, can you see my slideshow? Yeah.
Yeah, we can. Thank you.
Okay. So, and I think what I want to talk about in general practice in general was about rebalancing the inequality for a lot of our patients with learning disabilities. Now, sorry, one second, I'm just trying to get to the next page. Bear with me. Any people more clever with me know how I can move this on?
Do you want to come out of the...
Got it. Sorry. Thank you. So yeah, basically I thought it was an interesting but very sad fact that in the last year when we had COVID and the pandemic, if you had a learning disability, you were 6 times more likely to die due to the very fact that you just had a learning disability from COVID, because of the difficulties with accessing healthcare, with communicating, with making health professionals understand.
Sorry to interrupt, Jen. We are still on the same first slide. Were you supposed to be on the second slide now?
Okay, yeah. Is it not?
Sorry. No. There we go. Yeah, you've moved now.
Is that there?
Yes, that's working now, yeah.
Yeah. And also, I thought was really shocking was that the death rate was 30 times higher in the 18 to 34-year-old age group. So that video just about equality and inequality, okay, it wasn't exactly pertinent to learning disability, but I think we can draw from that and just realize how much work we need to do to try and bring people just up to the stage that they should be at to be able to access everything that everyone else can. So what we can do in primary care, just a few little points. One of the things is to code your patients as learning disability, okay? You don't need a secondary care diagnosis. If you think that they have a learning disability, please code them as such. In Hackney, we have about 1,000 patients or so known to the ILDS team, the Integrated Learning Disabilities team. And if you think that learning disability affects 1% to 2% of the population, you look at the population size of Hackney, there's about 3,000 missing patients here who are not on the register or not known to ILDS. And I know that a lot of practices have been working on this already due to the work by my predecessor, Anne Solomon, who was in this role before. But there's clearly a lot of work still to be done. And I think don't wait for a formal diagnosis. You'll know the patients, the ones that perhaps you don't always get the message across to, repeat attenders, and patients where they perhaps turn up to A&E because they don't understand the processes. And these days when we've moved to online telephone triage, etc., because of the digital poverty in this population, it's something to bear in mind. And the other thing about adding them to the learning disabilities register is that you will give them access to the annual health check. Now, some of you might be thinking, okay, that's a lot more work for us to do. But when you think of it, the long-term gain is worthwhile because they'll have access to structured and thoughtful healthcare. And the big thing, of course, is if they were on the learning disability register, they were added to cohort 6 for COVID vaccination in February of this year. So that really brought them up to, I think, where people should be. Your annual health checks, start calling the patients now. I know lots of things have been put off till June, but June isn't that long away. And call them in now while it's summer and the numbers are low. And also, if you can think now about identifying potential vaccination or screening difficulties, then know that the ILDS can be around to help as well. I've had some queries from some patients families of patients who felt that perhaps they needed sedation. I mean, that's pretty extreme, but it is available as an option if there's no other way of getting patients to have their vaccination. It's done at St Leonard's Hospital by the dental team, who are also, sorry, by the people who also provide the dental service. So they're very experienced with sedation if need be. The other thing I just wanted to bring to your attention was autism cards. Of course, not all people with autism have learning difficulties, although there is crossover. And it's just one of the really useful, handy things that we can do in primary care that we can give to our patients. And I'm going to attach some resources for this afterwards for where you can access from. Cynthia and Hackney ILDS have produced their own one, and this is the one that I'm showing here. But it's also available from National Autistic Society. And we'll add these links to the comments later. Okay, now I'm going to hand over to David and his team, who are going to talk for a little while, and then at the end we'll have a Q&A session for anything that you might have. Okay, I'm going to stop share. David?
Thanks, Jen. Thanks for the introduction. Just bear with me a second. Right, can everyone see my presentation? Is that coming up?
Yes, yeah, we can see.
Great. Okay, good afternoon, everyone. My name is David Breyer, and I'm a registrar in the Psychiatry of Intellectual Disabilities, and I work with the Hackney Integrated Learning Disabilities Service. I have with me two of my colleagues from my nursing team, Balabira and Zephaniah, who helped prepare this presentation and will be delivering parts of it as well. So just in terms of our aims and our content today, I just thought I'd talk with you briefly about our team and updates from our team. I thought I'd briefly touch on, you know, kind of the criteria for eligibility for our service. We'll talk about population and inequality that Jen actually spoke about. And Balabira will give a bit of information on accessing healthcare and how we can help you guys support our population. I have a couple of case examples. So one is of like a referral to our service, and you know, just I suppose to highlight the process of a referral, and another case example of a challenging patient that Zephaniah and I have actually, and the greater team, have been working with as well. And we'll hopefully have a good bit of time to answer any questions that you may have. And if you want to use the chat function to ask any questions, Jen is going to keep an eye on those, and we can bring them up at the end. And I'll have my details and the details of the service in the slides as well. So if questions don't get answered, or you have anything that you'd like to ask out with this presentation, please feel free to contact us. Okay. So who are we? We're an integrated service, which means that we work together with Hackney Council to provide health and social care input for our clients. So from the healthcare side of things, we have psychiatrists, psychologists, we have a behavioural analyst, occupational therapists, speech and language therapists, we have a dietitian, and we have learning disability and mental health nurses. And then from the social services side, we have social workers. We're based in St Leonard's Hospital, which is that building just on the left, just off Kingsland Road. That's where our clinical space is. And we're also based at Hackney Service Centre. We've had quite a challenging year, as I'm sure you can imagine, as we've all had. But you know, I suppose the complications with COVID was that for some time we lost our clinical area in St Leonard's Hospital because we couldn't secure COVID flows. but I'm pleased to say that we're back in action. It's recently reopened, and we're starting to see patients there again. As I'm sure some of you are aware, Hackney Council was the victim of a cyber attack, and it was the council that actually held all of our records. So that's proved to be quite a challenge, but thankfully we are getting back. We have retrieved some notes, not all of our notes by any stretch of the imagination, but we're also building a new and improved record system. In terms of, I suppose, our referral process, during COVID, we recognised that our referral pathway needed to be looked at. We found that people were waiting too long for eligibility assessments from when they were referred. And so we decided to approach, because we couldn't find that there was one particular problem with the pathway, we decided to use QI methodology to improve the pathway. And we have now significantly reduced our waiting time. So we've gone from months down to weeks from when someone is referred to when they have their eligibility assessments completed. One area that we worked on was to improve our referral form, which Zeph, if you could just share the link in the chat function. That will also be available on our website as well. About 80% of our referrals come from GPs. So it's great to get the chance to just talk with you briefly about your referrals. And I suppose I would just ask if you could please provide us with as much information as possible. Our new referrals form, it's I suppose there are a lot more prompts in it, and there are, you know, it's not exhaustive in what it's asking for, but the more information we have at hand, really, the better. Unfortunately, we're not very well connected with other NHS services. So you guys actually will hold a lot of will have access to much more information on your patients than we will. So if they've ever been known to CAMS, or they've ever had any previous like neurodevelopmental assessments or cognitive or functional assessments, if you could please attach those to the assessment, that would be great. And then it's just to return them to our, like the referrals can be returned via our duty system, which is that email below. So I suppose, yeah, if we think about the nomenclature of learning disabilities, it's changed quite drastically over the last couple of 100 years. You know, people with learning disabilities were called idiots and feeble-minded in the 1800s, and it was only with the advent of the NHS that more formal terminology was used. And in the 90s, we started referring to this population group as people as having learning disabilities. More recently, Western countries are adopting intellectual disabilities to define this population. But I suppose it's also not to lose sight of the fact that underneath all this, these are people that we're talking about. And it's how you would like anyone else to be spoken about, really. So it's just trying to, I suppose, respect the differences that we all have, really. In terms of our criteria, and these are the criteria, this is the criteria basically for that we've adopted for eligibility for our service. But this is in essence, you know, what a learning disability is. There are 3 criteria. And the first criteria is that the person should have a significant impairment of their intellectual functioning. So significantly reduced ability to understand new or complex information in reasoning, abstract thinking, and to learn and apply new skills. And essentially, if they were cognitively assessed, and usually we would do this with the WAYS, which is the Wechsler assessment of intellectual functioning, and we'd expect an IQ score of less than 70%. Sorry, less than 70. The second criteria is that they'd have a significant impairment of their adaptive and social functioning. And what this is looking at is their activities of daily living and how much help they need and support they need in looking after themselves, in looking after their environment, such as their home, in maintaining social relationships, so relationships with family, relationships with friends, and personal relationships, and other areas such as, you know, pursuit of jobs, ability to manage their finance, and ability to access healthcare. And then the final criteria is that the age of onset of these difficulties occurred before adulthood, because, you know, it's a neurodevelopmental you know, neurodevelopmental disorders that we are concerned with and that we're commissioned to work with. And so this, yeah, I think people, and we've identified this within our service as well, that there's, you know, people have struggled to discern the difference between disability and difficulty. And I guess it's unfortunate that the words are so similar. But I guess the way I think about it is that someone who has a learning difficulty, so someone who has problems with something like dyslexia or even ADHD, if we were able to give them reasonable adjustments and treat whatever the disorder may be, that they would then be able to kind of like attain a normal level of in their cognitive functioning and in their adaptive functioning, whereas someone with a learning disability, we don't have any interventions to enable them to perform as we would otherwise expect a normal individual. Just to give you a brief rundown of our referral process. So once we receive a referral, if the person isn't already known to our service, they'll then be discussed at our weekly joint referral panel, and that's attended by our multidisciplinary team. So we'll have a look at the referral and decide from there what is the next, the next appropriate step. So if we feel that we haven't gotten enough information, we might go back to the referrer and ask for more support, or just to see if they can kind of like give us any more information on the person. We might perform a screening checklist with the person or their carers, just to get a bit more information. Or we can proceed on to an initial assessment, and this is performed with a member from healthcare and a member from social services. And then following that, their assessment is brought back to our joint referral panel, and we discuss whether from this we have enough information to deem that person eligible are ineligible. For the borderline cases, for the cases that we're unclear of, we would then go on to offer more formal assessments. So that's cognitive or adaptive functioning tests. So like I said, something like a WAIS for cognitive assessments and an AMPS for adaptive functioning. So the WAIS is conducted by psychologists who are specifically trained to administer this test. And for the AMPS, that's conducted by occupational therapists who are similarly specialist trained in delivering that assessment. So if someone is eligible for our service, they'll receive health and social input from our service throughout their lifetime. But if they're ineligible, they'll be signposted to appropriate services. And I suppose just to highlight, if you feel that someone, if you think that someone, while they might not have a learning disability, while you might not be concerned about like their cognitive functioning, their level of cognitive functioning, if you nonetheless feel that they have care needs that are not being met, they are entitled to a Care Act assessment. And I spoke with my colleagues in social services who said that the threshold for a Care Act assessment is actually quite low. A Care Act assessment covers roughly 10 domains. And again, it's you know, in someone's ability to maintain a habitable environment, ability to look after themselves, their finances, their health and well-being. And if you have concerns in that regard, you can refer them for a Care Act assessment via social services and via that email access@hackney.gov.uk. For other neurodevelopmental disorders, you can refer to what was formerly known as CHAMRAS, but it's the City and Hackney Primary Care Mental Health Liaison Service. So we have an autism service and an ADHD service in City and Hackney, and referrals can go through primary care liaison. Or I believe, what's your is that electronic? I don't know, ERS, whatever that service is. So as Jen kind of pointed out, it's estimated that about 2% of the population have a learning disability. And if we look at the normal distribution of intelligence, what we're looking at is the people that fall within 2% here, so with an IQ of less than 70. And I suppose that would be a helpful way of maybe having in the back of your mind when you are considering a referral to our service, is whether you think that person, you know, falls within that kind of level of cognitive functioning with an IQ of less than 70. And as Jen said, we reckon there are about 5,000 people in Hackney with a learning disability, and just under 200 people in the city with a learning disability. And just over about 1,000 are known to us. So that's quite a number that are still out in the community. And that doesn't mean that they necessarily need our support. They can be living independently, and the vast majority of people with learning disabilities have a mild learning disability, and we would expect with the right adjustments that they can lead perfectly normal lives. And yeah, I suppose just to add a little bit more to what Jen mentioned at the start, that people with learning disabilities are 2.5 times more likely to have health problems compared to the general population. And I think if we look at the number of premature deaths, I think that's when we can see the stark differences. So even accounting for the comorbidities that we can expect in people with learning disabilities, such as, for example, the cardiac problems in people with Down syndrome, they're still dying a lot younger than they should be. So their life expectancy is 23 years less for men and 27 years less for women. And as I'm sure you're aware, people with learning disabilities are less likely to attend for the regular health checks or to take up on their screening programs, which results in significant untreated comorbidity later on down the line. I'm going to hand you over to Balabira, who's going to talk to you about accessing healthcare.
Hi, everyone. Hello.
Hi, Balabira. Yeah, we can hear you.
All right, you can hear me, all right. Yeah. Friends, my name is Balabira. Like David said and Jen, that people with learning disabilities tend to experience a lot of health inequalities in accessing services. This could be primary care services or even our own services. So according to the leader report, we find that the statistics that show and the different reports that have been written say by the Department of Health, including the MENCOP in 2004, or whereby they highlighted the differences or the inequality that people with learning disabilities were facing in accessing services. Because first and foremost, people with learning disabilities have got a right to care and to be equally treated, and the equal rights, which was amended in 2010, also under their human rights. They equally suffer or experience health issues that could be easily identified or treatable, and yet they end up dying early or having premature death. So different reports have come up, including the one that highlighted in Death by Difference by MENCOP, that was in 2004. Also, there was another report that came out into the confidential inquiry into the death of people, premature death of people with learning disabilities. So that being said, some of the recommendation was around us having to get more training, especially the health professionals, also understanding and having to do or including family in the assessments or when dealing with people with learning disability. So what we have got on that slide is just like statistics from the leader report of 2018 that states 75% of GPs did not receive training in regards to people with learning disabilities. Also, people with learning disabilities tend to be admitted in the acute hospitals. They're 26% are more likely to be admitted in acute hospitals than the general public. Yet, when you go to the hospitals, you find that sometimes people have not highlighted that this person has got a learning disability. So we as the learning disability nurses, we advocate that if somebody is going to the hospital, they need to be having a health action plan or a hospital passport for them to go with that document. That way, we avoid a delay in people having to look for background information regarding this client. Also, it just helps the professionals to understand better and provide a service for the person who has got a learning disability. And on the other side, it could also just prevent the person with learning disability having to display behavior and in the end not receiving the right treatment, because he may even end up being detained or given medication, unnecessary medication, and yet the only fear is just maybe a different environment. So it is important that all learning disability clients from the age of 18 do have a hospital passport. That way they can communicate. So I've spoken about the confidential inquiry to premature death. So it is quite important that all people have annual health checks, as mentioned by Jane, that we need to start identifying these unmet needs so as to be able to limit some of these premature deaths. So next, David. So here are just some of the barriers. Why do we think that people with learning disabilities do not access the services? Things like our own attitude. Once we hear about learning disability, we tend to only look or concentrate on the learning disability other than looking at the person and it as the holistic. So people with learning disability, according to the Department of Health, are people first. And the white paper Valuing People highlights that people with learning disabilities have got the right to have access to mainstream services just like anybody else. They also suffer a lot of unmet physical and mental health or undiagnosed diseases, yet that diseases that could be preventable. For example, somebody may be having epilepsy, or some of them may be suffering from constipation, maybe having high blood pressure, but if they come to our services and all we see is the learning disability, we may not be able to diagnose and treat what they're suffering from. So the next one is about us not having enough or adequate information for carers in form of, say, leaflets, or having to involve them in their care. So on the next slide, it's about how would we support people with learning disabilities to be able to access the services. First, is it about us having to make available information in easy read, ensuring that when we are giving them appointments, we either look at having to give the first appointment or last appointment. Also, ensuring that we look at the holistic needs, whereby we are able to identify whether they have sensory needs, meaning that we need to be offering them a quiet place. Also, annual health check should be looking at them generically, like from what I could refer as MOT, head to toe. So from the ear, nose, if that could be included, that would be very helpful. Sending them letters or text, because people with learning disability, especially those with mild, prefer text messages, because sometimes we do receive referrals from GP saying they're not able to get through to the person with learning disability, when actually maybe the person is not able to read or write. So it is important that we do try to accommodate that, communicate to people who are already working with them, ensuring that way we would be able to access their needs in a holistic manner. Also, it is important that we look at their communication or preferred method of communication. Next.
Yeah, and just to add, Zeph, can you add that link to the Easy Health forms? This is just a website with very good, like, easy to read information that you guys can use, just explaining what an annual health check is, or like, and various other appointments that we would encourage you to use to send out to your patients when you are offering them either their annual health checks, or if they're going to hospital for various investigations. And these forms provide a lot of easy to read information on various investigations. It's you need to register with the website, but it's free.
Yeah, even sometimes you could just Google it because it's www.easyhealth.org.uk, and then it will give you different options for what you want to do. So how can we help? So the way we can help is by working in collaboration with the GPs, the local GPs, or ensuring that if you have any difficulties, you can make a referral to us. That way we could be able to come out and maybe carry out joint assessments with the GP. Because sometimes when people learn with disability due to their communication issues, they do not feel comfortable with a health professional. So it does help when the LD nurses come around. It could be just with the parents because they already have the stigma in regards maybe to social service, what their experience was, and they could just decide not to cooperate. Also, what we tend to do, we do train maybe carers around health action plans, hospital passports, depending on where the referrer is coming from. And where there's difficulty with accessing the GP, we may still go and try to do some desensitization uh, training or medication training if there's been a highlight in a project or the carer is struggling, ensuring that maybe when we go to the GP, we are able to advocate for them and see if they could be able to get maybe the blister packs. And next.
That's great. Thanks, Albira. And just to say, we've issued some guidance in terms of the COVID vaccination, and if they're in anticipation of any problems you might be having, Zeph, if you can just post the link in the chat. It's just to help you guys support people with learning disabilities access the COVID vaccine.
Right, is that the end of
Albira, are you? Oh.
Yeah, because if we are able, sorry, I was just typing something. Sorry, what could be the benefits of somebody or us working collaboratively to our clients? They'll be able to have early intervention, or the unmet needs can be diagnosed by the GP or through any other special intervention. For instance, maybe by people having to be able to make the special referrals to the dentist in case of bloods, because we have been finding so difficult to get some of our clients to engage. So like Jen said, we are trying to work with the dental staff at St. Leonard's to ensure that those unmet needs are diagnosed so as to prevent any early death. Also, we try to, by us working with the people learning disability, we are able to prevent the frequent calling in A&E, because some of our clients, much as the GPs are offering them like to flexible hours to try and see them in the GP surgery, they still end up going to A&E. So sometimes when we are in the community, we are able to meet them, and if we speak to them that way, they're not able to heavily be calling the accident and emergency. That they are aware that anytime we can see them, so they tend to be coming over to us. Also, it helps to reduce unnecessary hospital admissions, because people learning disabilities, they do not like, some of them do not all like the change of environment. And once they go there, they may be going just for a simple intervention, but they may end up staying there longer because either their behavior has changed and they may end up getting the unnecessary medication when they don't actually need it. So what we tend to try to do is to try to work with them and maybe give them some easy read, try to understand. It doesn't matter. Sometimes you have to continue visiting them, because one off does not mean that you have to discharge that person. It's totally different. For mental health, once you've gone to make that visit or you made the contact and the people do not open up the door, they tend to discharge. But with LD, we tend to be hands-on, following them up, giving them several appointments. And it may take a while, but they will come around. So we just try to do a lot of risk management. Also for those that need continuing healthcare, we do work with family, we do work with different professionals to just enable that at least their well-being is looked after and they're able to contribute in society.
Thank you, Balabira. I'm just going to draw that perhaps to a close, just to give us a little bit of time for the Q&As, but that was super helpful and very interesting, I found. I'm just going to address a few of the questions that have come up first, David, if that's okay with you.
Yeah.
And then we can go on to any Q&As after that.
Do you want to stop? Sorry, do you want to stop sharing the screen, or do you want to leave the contact details up while?
Yeah, I'll just leave. Just for a couple of minutes, if any of you want to take down, these are our contact details, and that's the contact details of the two consultants that are within our service. So if you've any queries or anyone you'd like to discuss, please don't hesitate to contact us.
Okay. Thank you. So one of the questions I think came up from Paula Stanley that, at the start of the pandemic, some patients who had support workers suddenly lost their face-to-face support and haven't been seen since. What is the plan for that? And is this going to restart for face-to-face support?
Yeah, absolutely. So we in psychiatry, we continued to see people face to face throughout the pandemic, and while day centres and support services did kind of temporarily close, they are now reopening. It was done on kind of like many of them were based on a risk assessment and assessment of need. But some patients, I have a patient in particular who's very fragile and bipolar, and we found that actually she needed community access. So she was seen throughout the pandemic. So if you are finding that that carers or support staff are reluctant to return, please let us know. But we are finding that people are going back and support staff, their services are being used again, and day centres are reopening.
Okay, that's good to know.
And I can come in on that.
Yeah.
We actually don't have much support with support workers. Usually when we have a support, we have only 2 support workers within the team, and they are only allocated for a piece of work. So we can look into that issue separately, privately, yeah. So we can try and make a follow-up on that.
I think you're referring to care providers, is that right, Jen? I assume it's care providers.
So this is the question from Paula Stanley. Paula, are you there? Can you unmute yourself perhaps to make this clearer? No, perhaps not. I think what the question said, I had a terrible experience of a patient known to the LD team who had a dedicated support worker that just disappeared, no phone contact, nothing at all at the beginning of the pandemic. And we're told by your team that they were working from home, which is obviously not suitable for this particular patient.
I have unmuted now, if you can hear me.
Yeah.
I'm working from home, so I'm video free because I'm a bit shriveled. Or rather, this is my day off. I'm not working from home. None of us are anymore. Yeah, and as a patient, she completely, her support worker, she had a lifestyle coach. And I hear what Zeph says. I know that support workers are different, who was shopping and exercising with her every week. And they disappeared at the beginning of the pandemic. And I've spent ages chasing the patient up. And she has put on 2 stone over the year, because she hasn't had her lifestyle support. She's a very high need learning disabled patient. When I contacted the LD team, they said, oh, it's because we were hacked, which I thought was very unsatisfactory. They should have a way outside of the electronic system of tracking who has contact with the LD team, support people, be they lifestyle or support workers. To GPs, we would call them all support workers. Who are facilitating their ongoing physical health. And this lady just fell off and she's now in a very poor way. And I've struggled to get her plugged back in again. I was then told her support worker was working from home, which obviously is not going to work.
Seth or David, what do you think?
I'm sorry to hear that, but it is really unlikely. Normally, when we are working with service users, like what Paul is saying, it will be just a short piece of work. And all our clients, those we knew or even those we didn't know, we are working with them throughout. Though, yeah. So what I would suggest is if you give us the details privately after this, we can actually look and identify who is the service user and who is the person who was working with him.
Yeah, I think that's a good idea because it's quite specific.
Yeah,
Perhaps,
yeah.
Paula, if you could email the team and then they can look into it directly for you. The other question that you posed, which I think is good for the general population as well, is it would be nice for the GPs to have a list of who is known to the learning disabilities team who are in their practices, because it's not always obvious. So I think that's something that we can work together with, actually, David. We can do some searches and perhaps let practices know. Patients do change where they are registered sometimes. So, but can we look into that?
Absolutely. So that's just that so it's that sometimes GPs don't realize that patients are known to our service. Yeah, absolutely. We can look into that. Yeah, for sure.
And there was a question from Charlotte Morgan at Loss in Practice, who also said that there isn't much support for people that fall into this gap of mild to moderate learning disabilities. They don't qualify for the full ILDS. However, they could really do with some support. And I'm just wondering, part of that, what you mentioned, David, about the CARE Act assessment, perhaps that is some of the stopgap. I have to say, I wasn't very aware of that myself. Can you think of anything else?
I mean, I think if someone has a moderate learning disability, they would so they would definitely meet the criteria for our service. I'm just wondering, and again, this is where the distinction between difficulty and disability comes in. So we would, it's the borderline patients of a mild learning disability. So where their IQ is about 70, that we would, if they are able to function independently, they might not be eligible for our service. But someone with a moderate learning disability, I mean, that is an IQ of less than 50, and so they would, we couldn't expect them to live independently. So I think what you're referring to there is someone with a mild to moderate learning difficulty. And in those situations, yes, absolutely, they might be eligible for a CARE Act assessment, and it'd be worth referring them for that. There's also a social worker that specializes in autism. So if you have patients with autism, and again, they might not have a learning disability, so while they'd be ineligible for our service, they would still be eligible for a CARE Act assessment, and there's a dedicated social worker that conducts those assessments.
Okay, and on from Charlotte again, and this actually does lead to some of the questions that we were talking about before, David. It would be helpful to set up some clinician training in sexual health for this group of patients. It's challenging to assess capacity to consent some patients. And also, I suppose this is to do with cervical smear, and the health screening that we offer, and working around capacity and whether it's a suitable test to offer. Do you have any ideas or leads on that?
In terms of the cervical screen, so my understanding is it would only be if someone is sexually active that they'd require a cervical screen. Is that correct?
It's if they've ever been sexually active.
Yeah. So I suppose that would have to be kind of considered on a case-to-case basis. Our nursing staff, I'll invite you guys to come in here, but from what I understand, you guys provide sexual health education, can provide sexual health education to patients. Is that right, Zev?
I think the sexual education that we provide to them is on a one-to-one basis, but when it comes to having to assess the mental capacity, it will be up to the person who is going to do the smear test or the screening. Because what we'll tend to do, we'll have to give them like an easy read or to try and sit down with them to explain why it will be important for them to have the screening. But you find that some people with mild learning disability tend to decline. So if they decline that they do not want to have the screening, then we cannot really force them to have that medical intervention.
I suppose this links into capacity for consent.
Yeah.
And I think that Charlotte's just added there that she actually meant consent to sexual relationship. So it's the step before the smear even, you know, whether they had capacity to consent to sexual relationship.
Yeah, sometimes the psychology try to work with them depending, like what David said, it depends on the individual needs of that person. So they could call them in and find out what is happening. So we still have some easy read information that we could share with them. So you can still make a referral and then we'll go through the screening.
Yeah, absolutely. If you have any concerns about with capacity and capacity assessments, please, you know, discuss them with us. We're more than more than happy to advise and help with and support with capacity assessments. Absolutely.
For our very last question, and perhaps it's a brief one, someone has said, what is easy read text? We keep talking about easy read. What is easy read? Can you just say in 30 seconds?
Yeah, so I mean, if you actually look at that website that we pointed out to you, the Easy Health, so it's a lot of pictorials, it's easy to, it's like big text, not that much words. It breaks it down and it's very much simplified. But if you have a look at that website, they have a lot of easy read information, examples there. And if you find that you've not quite got one there, please come back to us and we can try and provide you with something.
Okay.
They're also available on the College of Psychiatrists website as well.
The reason why we tend to use easy read is because majority of people learning disabilities do not really communicate verbally, or they do not know how to read and write. So it is important that the information is put simply in maybe one sentence or a few words, and using pictorial, accompanied by the pictorial, they will be able to understand and try maybe to consent. For instance, when you're saying that they're not going for the smear test or consenting to having the smear test, if they see the visual side of things, they will be able to either understand and say, okay, maybe I could have a trial. That way you could try maybe 2-3 times, go with them to the clinic. And when they feel like they've seen the posters or they see people there, they could be able to engage with the services.
And I guess we could also access this for our patients without learning disability or otherwise, you know, the patients that don't read or write. We have, I'm sure all of us have them within our practice. So
please feel free to contact us if you ever have any queries. That's what we're here for. And we're very happy to support and to strengthen our relationships with our GPs. You guys have a lot on your plate and we're very happy to help you, especially with our client population. If I could just ask you finally, we're just going to post a questionnaire just on the teaching, just to find out how helpful you found it or not. If you wouldn't mind completing it, will only take a couple of seconds. But thank you very much for your time and for inviting us this afternoon. We're very happy to attend.
There will be a survey that goes out anyway, David, that we'll share the results with you from as well, because in order to access the certificates for their CPD, the GPs need to complete a survey. So we'll have that for you as well. So hopefully you'll get feedback across both.
Thank you very much, David and team. I think prepare to have a few emails, and I think social services are going to get a few emails for their health assessment, Health Act assessment as well.
Yeah, absolutely. Great. Okay, thanks guys.
I will circulate slides and things as well to attendees. If there are any additional resources like the referral form and things, if you just want to drop those to me in an email, then I will get those around to attendees as well. Thank you so much. Thank you to all presenters for your time this afternoon. Thank you attendees as well, obviously, for sitting and listening, and I'll hopefully see some of you again next week at the next education event. Thank you all. I will stop the recording and we'll end now. Thank you. Bye-bye.
Bye-bye.
Thank you.